Good morning. I'm Molly Galvin with the Academies Office of News and Public Information. I'd like to welcome all of you here in the room today and all of those viewing the webcast for the release of this new report, Making Eye Health a Population Health Imperative, Vision for Tomorrow, from the National Academies of Sciences, Engineering, and Medicine. The report and related materials are now available online on our website, nationalacademies.org. Our briefing today will last for about an hour. The committee members who have joined us today will provide a brief overview of the report's key points, and then we will open the floor to your questions. We ask those of you in the room to step to the aisle microphones to ask your questions, and please identify yourselves. Those webcast viewers who would like to submit questions, just follow the directions online, and you can do that at any point during the webcast. You can also join our conversation on Twitter using the hashtag iHealth. Now I'd like to introduce our committee members joining us today. Steve Teusch is chair of the committee and former chief science officer with the Los Angeles County Department of Public Health. Ann Coleman is professor of ophthalmology and epidemiology at the Stein Eye Institute and the David Geffen School of Medicine at the University of California, Los Angeles. And Ed Marshall is professor emeritus of optometry and public health at Indiana University in Bloomington. I'll turn it over to Steve now.
Thank you very much, Molly, and thanks to all of you who are joining us here in person, as well as those of you who are on the webcast. We really appreciate your interest in this work. Molly introduced the National Academies and some of the new terminology for the organizational structure here. I'm not going to go through that, but the Academies have been, of course, a scientific leader to make sure that we have evidence-based policies and programs in this country for over a century. Here's a list of the committee members. It was a diverse and enthusiastic and very committed committee that had optometrists, ophthalmologists, public health experts, and members of the consumer community. Many of you in the room and hopefully on the webcast are our sponsors, and you can see we had a very rich set of sponsors for which we're very grateful. This work obviously would not have happened if it were not for all of you, and hopefully we've delivered a product that you can then use to help improve the vision of people in this country. And I'd be remiss if I didn't acknowledge the incredible work of our staff. It was led by the study director, Meg McCoy, and under the leadership of Rose Martinez, who leads the Board on Population Health. In brief, this is the statement of task, and it was to really look at how public health and the vision communities can come together. And our task was to understand what the current limitations are in our information systems and surveillance, to examine issues surrounding health disparities and to promote health equity, to look at the knowledge base and what kind of evidence-based strategies can be implemented, and to look at how these conditions impact people with eye conditions and with comorbid conditions, and what we can do as a nation to come together to improve vision health in the country. So let me get into the meat of our work. In brief, this was sort of how the committee looked at the progression of eye disease, so that on the far left you'll see the individuals who are healthy have no known or detectable eye health conditions or vision problems. But as they progress, there is often subclinical or structural changes that are detectable by clinicians, not so much by individuals. And then things progress to a clinically observable state. And of course, at each of those stages, one hopes that one can intervene before there is a functional impact and a long-lasting impact that becomes uncorrectable. One of the challenges the committee faced was terminology, and we found the field fraught with different definitions. And so you'll see in the report an extensive discussion of that. I'm only going to highlight a couple of things here. One is that we considered vision loss as the process by which there are physiologic changes in the eye. So you can think of it as the process of the progression of disease. Whereas vision impairment, which we think of beginning when it becomes clinically apparent and apparent to individuals that they have problems with their vision. So vision impairment is really the state of their vision health. We looked at a wide variety of data, and you'll find that in the report, of course. I just want to highlight a few things that suggest why this is a condition of significant importance. One is it is extraordinarily common. Over 140 million adults over age 40 have some type of vision problem. 6.4 million Americans have uncorrectable vision problems, whether that's vision impairment or blindness that can't be reversed. You'll see a high level of uncertainty here in our next number on simply the number of people who have uncorrected refractive error. It's between 8 and 16 million people. That both reflects the uncertainty of our data and the problem we had with coming up with solid numbers, but whether it's 8 million or 16 million, that is a lot of people who are in need of care that could be readily corrected. You can see that we have over 1 million people with uncorrected cataracts, 2.5 million people suffer from eye injuries every year, and all of this leads is an enormous cost to society, both in terms of the direct healthcare costs as well as the broader indirect costs, and it comes to close to $140 billion. And this problem is going to grow. You can see here that between now and 2050, the number of individuals who are going to have visual impairment, if we don't do something, is likely to double. And as all of you know, the vision loss takes a significant toll. It's absolutely critical to children who need to get good educations, to socialize, for working adults, families, and as people progress into older ages, the toll of vision impairment leads to nursing home care, very large burdens on the family in terms of caretaking. And the condition itself is complicated, often associated with many other chronic diseases, and is associated with many of the important mental health problems associated with depression, anxiety, and related conditions. By its very nature, we're so dependent on eye disease, it complicates the management of other conditions, other health conditions, and it complicates the management of eye disease itself. So one of the challenges that we faced was that we have a public health community that isn't all that familiar with the problems of vision and what they can do about it. And by the same token, we were challenged because the eye community, which has been so successful in terms of the clinical management, hasn't necessarily thought about things in the broader population health focus. So this figure is intended to sort of portray both what we were trying to achieve and how we see bringing these different views together. So at the top and the bottom, you'll see the overall goals. One is to obviously improve eye health and vision health in the country. But at the bottom, you'll see that equally importantly is that we need to achieve health equity. So let me describe the middle of this figure, which you might think of as a cylinder. And looking at the 3 segments to the far right, you'll see primary, secondary, and tertiary prevention, which many of you will be very familiar to you. Primary prevention being the strategies to prevent diseases or injuries from occurring in the first place. Think of it as risk reduction. Secondary prevention being the early detection of conditions when they still can be treated and reversed, and tertiary prevention, again, about clinical management and maintenance of function for those conditions that are not correctable. But I would like to talk a little bit about that segment on the far left, for which there is not a euphemistic term, and we call it here primordial infection. And those are really the upstream conditions that are not unique to eye and vision health, but underlie many of our problems in health. And that really relates to the social and environmental conditions in which we all live, and which are critical if we are going to solve the problems of health inequities. So it's our education, it's the environments in which we live, our built environment, poverty, health literacy, many of those conditions, which are essential for us to address if we're going to really solve these longer-term health problems. So that's sort of the health picture of it all. From the public health and population health, those of you in the field will certainly recognize on the left the core functions of public health, which are assessment, policy development, and assurance. So assessment means we need to understand what the nature of those problems are and have the information to solve them. Policy development means we need to have the programs and policies in place that can be used to address those issues. And assurance means that those things must be delivered. It doesn't mean the public health system will necessarily deliver them, but it has a responsibility to assure that that people have access to the kind of care and healthful conditions that they need. In the middle of this figure, you'll see the 10 essential public health services. I'm not going to go over them in detail. In the middle, I will just indicate that there's a strong research component that provides the necessary information. And surrounding it, you'll see where it says system management. Much of what we're going to be talking about is how do we improve the systems, not only the systems of healthcare and how we integrate care and eye care into the healthcare system, but the systems that we have in society more broadly. I'll talk about those in a moment. So this figure is one that is familiar to population health, the population health field, and it betokens sort of how we think about the determinants of health and where there are opportunities to intervene. So in the middle, we have the individual, the basic biology, our innate traits, that you can think about as the biology of disease. But surrounding that are our individual behaviors, which influence those outcomes, our families, and the social conditions in which we live, which also influence our behaviors and our ability to address problems, and living in working conditions and the broader social, economic, and health policy environments in which we all live. And the important message here is that if we're going to solve these problems, we need to have interventions that at all of these different levels if we're going to make important inroads in improving population health. I won't go in detail about these boxes on the outside, but you'll see that we're talking about behaviors, what do we do about social determinants of health, access to care, promoting healthcare quality, and you'll see that we have indicated, provided examples of the things that can be done at each of these stages within the clinical care environment, for changing behaviors, the kind of things that are going to be important on the policy front, and changing the conditions in which we all live. And it's that comprehensive approach that we think is that underlies the basic message of this report. The report itself and the committee developed a set of core principles, which you'll see on the outside of this circle, which grounded our thinking about the work. That we need to have, we thought about the resources that are required, the kind of collaborations that are needed, how we tailor these conditions, tailor the interventions to meet the needs of specific communities, how we assure that they are culturally competent and appropriate, that they're evidence-based, that there's a strong science base for what we do, that they're integrated, population-centered, thinking about the population more generally, not just the people within a care system, and that we have a standardized, harmonized set of approaches and information. So with that, by way of introduction, we have Ann Coleman, who's going to start presenting what the recommendations of the committee actually are. And I would say you'll see here, as you hear Ann and Ed speak, that the recommendations are very broad. There's a lot of work to be done. We try to provide lots of examples and detail in the report, but these are broad strokes about what we think need to happen if we're going to achieve the kind of health system and vision health that the country deserves. So Ann, thank you.
Well, thank you, Steve. So I'm going to, there are 9 recommendations, and I'm going to be going over the first 4. And the first one is that the committee felt very strongly that the Secretary of HHS should issue a call to action to achieve a reduction in the burden of visual impairment across the lifespan of individuals in the United States. And this is really our recommendation, that we start having a discussion about what we're going to do. When you have about 140 million people that have vision problems, this is a huge problem in this country, and we really need to start having discussion about it. We felt that it was important to have a lofty goal, and so we really wanted to aim to have the elimination of correctable and avoidable vision impairment and blindness by 2030. It really doesn't make sense that in the United States there are people that cannot see, cannot function because they don't have the right eyeglasses. So this is a goal that we felt should really be of the country's. In addition, it's important for there to continue to be work on delaying the onset and progression of unavoidable chronic eye diseases and conditions, such as glaucoma or macular degeneration, and start looking into those, in addition to diabetic retinopathy. In addition, there's another population that is affected, and those are the individuals that already have chronic vision impairment, the individuals that are already blind or having difficulty, and we really need to be addressing the rehabilitation of those individuals by society also, so that they can have a good quality of life. And we're also very interested in achieving eye and vision health equity by improving care in underserved populations, because a lot of times it's the underserved populations in this country that are impacted by this burden, and we really want to address that too in this call to action. For recommendation 2, we really felt that the Secretary of HHS should organize a coordinated public awareness campaign. And we've had a suggestion of many other individuals, professional organizations, employer, state, and local public health agencies, and other federal agencies that should really join into this. But there really needs to be public awareness about vision impairment. What can people do for their vision health? How can they protect their eyes? For example, using protective eyewear, since you have about 2.5 million eye injuries a year in this country. And so we felt it was very important to launch a public awareness campaign. For recommendation 3, we felt that the CDC should develop a surveillance system for eye and vision health in the U.S. And convene a task force comprising government, nonprofit, and for-profit organizations, also the professional organizations, academic researchers, and the public and public health sectors to really design a system that's going to allow us to measure what's happening in this country. Because we do have visual impairment and blindness and eye diseases, and currently we really haven't had a system that's measuring what's happening in all the localities. And if you don't measure it, you really can't improve it. You really can't make changes. And even if you do try to do interventions, you're not going to know it makes a difference if you're not surveilling the system and seeing what's happening. And so we highly recommended that. In addition, we felt that HHS should create an interagency work group. And this was really to set a common research agenda. It's not that there hasn't been research being done in the United States on vision and eye health. It's just it hasn't been coordinated. And we do have institutes that are just focusing on the eyeball and not really looking at the whole system. Because, as you know, our vision affects many of the things that we can do as individuals. For example, for diabetics that are losing their vision from diabetic retinopathy, it could impact how they actually give themselves insulin or the pills that they're taking because they can't see them. And so vision is very much coordinated into the health system, and yet in terms of how we've been providing healthcare in this country, it's been kind of siloed off by itself. And so we're also recommending that there's health services research to really look at the health system so that you don't have vision and eye care off in a silo so that you're not treating the whole person. In addition, we're recommending more research on the determinants and risk factors for different eye diseases, especially common eye diseases. A lot of times we get questions from people, what can they do to help prevent problems? And we really can't always answer it because the research hasn't been done. And so this is also a call to action to do this. And I'll now step aside and let Ed discuss the next 5.
Thanks, Ann. The next 2 recommendations relate to expanding access to clinical care. As you may be aware, a key component of population health is ensuring that care is both timely and appropriate across all populations. And a key driver of ensuring that is clinical guidelines. Clinical guidelines basically give us information and direction about what should be provided, to whom, how often. Unfortunately, within the eye care world, we do not have a single set of evidence-based clinical guidelines. We do have clinical guidelines, but there are differences, particularly as it relates to the type of care, the frequency of care, as it relates to asymptomatic patients. So recommendation 5 calls upon the Department of Health and Human Services to convene a panel to look at, and this panel should consist of the various stakeholders within the eye care, not just the eye care world, but healthcare practitioners, organizations, researchers, public health practitioners should come together to develop a single set of guidelines that are evidence-based that will give us direction in terms of the frequency and the type of care that should be provided to populations, particularly vulnerable populations, that all health professions, the public, other stakeholders can use to help create policies and programs that will address vision health. These guidelines should include, but not be limited to, the schedule and components of comprehensive eye exams, the appropriateness of particular diagnostic treatment and management strategies for specific eye diseases and conditions, and thirdly, criteria to facilitate appropriate follow-up care, both within and external to the vision care world, to ensure a continuum of healthcare that is focused on the specific eye needs and the overall health of the populations. The next recommendation, recommendation number 6, also addresses access. Well, in this case, it relates to the education of health professionals, the education and training of health professions. There are historic divisions within the eye care world. And for that reason, too often, our eye care is not coordinated, is not well integrated. So we feel that the educational systems need to be pay more attention to including population health within the curricula of health professions education, both within the eye care world as well as outside the eye care world. The public health professionals need to understand the importance of vision health, and vision health professionals need to understand the importance and the engagement of population health. Also, as our population continues to change demographically, it is important that we work more strenuously towards increasing the diversity within the healthcare workforce. This also speaks to the issue of cultural competency, to make sure that all populations are receiving care that's most appropriate for them in terms of their values, expectations, and their needs. The next recommendation, number 7, looks at how can we better enhance public health capacities to support vision health activities, integrating eye and vision care within the public health community. And a major driver of this, obviously, would be the state and local health departments. They are natural conveners of the various stakeholders that need to be involved in a population health approach towards reducing vision impairment and promoting vision health. State and local health departments, along with their partners, can enhance community needs assessments, looking at quality improvement measures, identifying, eliminating barriers that exist to improving vision health, improving the functioning of individuals with vision impairment, including and also include public health and clinical expertise on panels. State and local health departments many times will have committees, expert panels, but do not have the advantage of having vision care providers on those panels or even public health experts on those panels to help look at what's best in terms of a population-based approach to eliminating vision impairment. The next recommendation looks at, well, it relates to engaging CDC in assisting those local and state health departments. One problem, as we all know, that local and state health departments are more and more constrained these days financially and do not necessarily have the resources to expand their programming. They also, unfortunately, do not recognize too often that vision impairment is a chronic disease and should be included on their chronic disease agenda. We are recommending that CDC, which has a vision grant program, currently I believe that vision grant program provides about $25,000 to 3 states to promote policies and programs around vision health. Well, we feel that is insufficient and that CDC needs to, should be able to expand that program to better assist states and local health departments in advancing a vision health agenda, which concludes designing, implementing, and evaluating programs for the primary prevention of conditions leading to visual impairment, developing and evaluating policies and systems that facilitate access and utilization of patient-centered vision care and rehabilitation services, and developing and evaluating initiatives to improve environments and socioeconomic conditions that underpin good health and vision health and reduce eye injuries in communities. The last recommendation speaks to the role of communities. Public health is local, and unless the communities themselves are engaged and invested in the process, we will not get very, very far. So communities have a lot of resources at their disposal. Communities also are not homogeneous. They vary in their demographic makeup, they vary in their needs, they vary in their resources. So communities should be able to collaborate with state and local health departments to design programs and policies specific to their individual needs around eliminating barriers that exist to receiving comprehensive eye exams, barriers that may interfere with the ability to receive health screenings, vision screenings that are highly sensitive and specific, barriers that relate to the social determinants, looking at, say, the built environment, making sure that there's ample facilities for children to be outside, to help in terms of their visual development. So these are the recommendations that we have developed, and it's important to also understand that in terms of the community engagement and the other stakeholders that we recommend should be at the table, Chapter 5 includes a variety of examples that communities and other stakeholders might engage in around advancing a vision health agenda. Those activities can include such activities as improving eye and vision health awareness among different social groups and communities. We know that awareness is a significant problem. Many people believe that they do not access vision care providers because there's no need, even though they may have an existing vision health problem. Engaging community organizations and groups to promote eye and vision health awareness in daily activities, for example, using protective eyewear. Establishing and enforcing laws and policies intended to promote eye safety and functioning of people with vision impairment. Identifying the needs I mentioned before of various barriers, community-level barriers that interfere with vision-related services and the use of available resources. And adopting policies, creating community networks that support the design of built environments and the establishment of social environments that promote eye and vision health and independent functioning. As you review these recommendations, you will note that they are highly integrated and they build upon each other. The ones that I just referred to kind of start at the national level and drill down through the state into the community. All sectors have to be involved if we are going to have a population-based approach.
Thank you very much. We're now going to open the floor up to questions. Again, those of you in the room, if you could step to the aisle microphones and please identify yourselves. Don't be shy. Well, why don't I get things started? So these are a broad set of recommendations. There are a lot of parties involved. What would you say are, the next steps now that the report is out?
Right, and thank you, Molly. And these next steps are really important. It's a long report. There is a lot of detail. There are a lot of specific examples. And it'll take a little bit for individuals and organizations to digest them and think about what their potential implications are for them as individuals and as organizations. And we hope they can then come together to develop some common strategies. Next spring, we hope to convene many of the stakeholders to actually talk about how they've progressed and to talk about how they might come together in the future to actually move to try and implement many of these recommendations. So we see it as this report is just the beginning of a process that we hope will unfold over months and even years.
And there are questions from the public listening in online. A question from an anonymous listener. Did the committee discuss the role of public health vision screenings, i.e. in schools, preschools, community health centers, primary care environments, in supporting a strong population health approach to eye care?
I'm going to speak generally, and then I'll turn it over to Ann and Ed to give a bit more richness from the practitioner's perspective. Many states, actually most states, have requirements for vision screening, but there are those that don't even have that. And there are very, very, very few states that actually have systems in place to actually assure that the children who are identified as having vision problems actually get the follow-up care that they actually need. And obviously it's imperative. Screening by itself is just the start. We need to make sure that the children get the care that they need so they can function well. So there's a lot that needs to be done on the system side to make sure that happens, and at the policy side. And then, of course, there's the technical details of what needs to be done. And for that, I need my eye professionals to talk about.
So the committee did discuss, it is in the report, about vision screenings, especially with the children in the schools. And one of the things is that we recognize that the eye examinations, a complete eye examination is the gold standard, but that we don't really have the resources in this country to give every child an eye examination. And so it is important to have screenings of children so that you can pick up eye diseases such as strabismus or amblyopia or lazy eye, because this can really affect the development of that child and also their learning in school and be something that they have for the rest of their life. So we do recommend screenings, but that is discussed in the report.
I might add that all screenings are not the same, and we must make sure that when screenings are used, that they are of a sensitivity and specificity that will help them identify any problems that might exist within the population that's being screened. And I think that's a key element of any screening program, particularly from a population health perspective.
A further question from the listening public. In recommendation 5, you say that evidence-based guidelines should be used for payment policy. Are there specific policies you target or discuss in the report?
So, Steve, we do discuss that at some length, and I think that there was a lot of concern in the panel, and it's reflected in the report, that many of the basic eye services that people need, particularly corrective lenses and devices for rehabilitation, are not systematically covered in this country. And as we move from an indemnity kind of system to a system where we think that all basic services should be covered, we think that this needs to be addressed. And one mechanism for beginning that process is to have a set of evidence-based guidelines about what people should all be getting that are consistent and have a strong science base that then can be used by payers to begin to fill these gaps and make sure that they happen. The committee did not weigh in specifically about how that insurance needs to be provided. There's a lot of different options, but the fact that there are these big gaps we felt needed to be closed, and it particularly related to lenses and rehabilitative devices. Yeah.
I think Steve adequately covered that. The guidelines can direct payment policies, but also direct what sort of devices, corrective lenses should be provided to whom and when. And we know that many programs will restrict or not even address the issue of corrective devices. Medicare, for an example, in terms of not providing corrective lenses for asymptomatic patients, and that's a population that can be highly vulnerable, particularly in terms of age-related morbidities. So we want to be able to have evidence-based guidelines that will direct payment policies, but also address the issue of the provision of corrective lenses and assistive devices.
If I could add one more thing, there is a table that talks about Medicaid coverage by state, so you can see that how that even something as basic as that varies from jurisdiction to jurisdiction.
A further question from John Wiles, who is attending remotely. You mentioned many different stakeholders in terms of accountability in enacting these recommendations, but on which stakeholder you see the most onus resting? Government, professional organizations, private organizations, nonprofits? Who needs to step up more than any other?
Which of your children do you love the best? You know, one can point out that one needs leadership from different types of organizations for each of them. And the report points out that each of these groups has really an important role to play. Some of our other reports, and I'll point to one we did out of the National Academies on public health strategies, really talks about the mutual accountabilities that one needs to have if one's going to have a comprehensive program. Each group, whether it's a professional organization, a community group, a state government, you know, any of a number of other stakeholders, could be the education department, that all have a role in this, and they are going to need to not only step up, but hold each other mutually accountable. There is not a single player here that is going to have the sole responsibility. There are people that are going to have different responsibilities at different levels, whether it's through hospitals and their community benefits, whether it's people who are managing chronic diseases, whether it's folks who are trying to create a health literate population. These are all different groups, and I think that it's fair to say that we look to our government for much of the leadership, but they're not solely responsible, and one can make great progress if the various stakeholders do step up.
I might add that, public health and population health more specifically is collaborative and integrative. And so all stakeholders have to be, I think, engaged and invested in the process. They each have, as Steve said, each of them has a specific role to play, but it has to be integrated across various platforms.
And I'll just add, in recommendation 1, we asked for the Secretary of HHS to do the call for action. And so we were calling out that individual.
Hi, good morning, good afternoon. James Cherkasky, National Alliance for Eye and Vision Research. Just a comment and then a question. We have 22 emerging vision scientists doing 50 Hill visits today about the value of vision research. It's a small part of what we have to do, but we're out there getting the word out there on awareness. I found it interesting, I believe it was yesterday, that NASM also released a report about the importance of caregivers for the elderly and how our system needs to really look at how care is going to be available, particularly with shrinking family members, et cetera, that are available to provide elder care. Of course, we know that with respect to vision, we have the increased incidence of age-related macular degeneration, age-related eye diseases. I just thought, wondering if the panel would want to comment, not specifically on yesterday's NASM study, but just on the role that family and caregivers and others in the vision space that accounts for a significant portion of those indirect costs.
Well, you've identified an important issue, and we talk at considerable length about many of the geriatric issues and aging, and not only the burden that it places on caretakers and the salience of this for people to live independently. I can't say that we address these in great detail about what the solutions are, but we believe that with greater attention to vision, many of those burdens can be significantly alleviated by both preventing those conditions, slowing their progression, providing people the kind of supportive environments, community supports that they need. And these are people who often have complex chronic diseases. There's a great deal of discussion in the report about multiple chronic conditions, of which vision is a part. And I would probably be remiss if I didn't say that vision needs to be on that list of important chronic diseases, which it currently is not, frankly, so that it gets the kind of attention that it deserves, and we devote the kind of resources and create the kind of social supports and systems that allow that those things to happen. Obviously, no magic bullet here, but if you noticed on the side, we talked about the silver tsunami and the increasing rates. And because eye disease is so much more frequent in the elderly and takes such a big toll on them, the aging population is going to become increasingly burdened by this, and we need to discuss that. We need to address that in a comprehensive way. We weren't constituted to do that on our panel, other than to highlight the needs and opportunities.
It's also important to realize that this tremendous burden that we're talking about, this vision health impairment, affects not only the individual who's visually impaired, but it affects society at large, including family members. And too often, services might be available, resources might be available, but they do not access those. And they may not access those because they have not been geared or directed towards those services. So healthcare professionals, both within the eye care world, as well as those within the public health world, as well as those within the community, need to be aware of what resources exist within their community, particularly around rehabilitation services, so that people who are visually impaired will be able to be directed towards those services and take advantage of those services.
A question from Dean Venisdale, who's listening in remotely. It's a question about the report recommendations. He states, the CDC's Vision Health Initiative is a relatively small group within the CDC. Are there recommendations to increase the resources and expand the capacity of the Vision Health Initiative or other specific government organizations?
I think I mentioned earlier that, yes, it is a relatively small program currently, and we believe that funding needs to be increased to allow CDC to better support state and local health departments in advancing their vision health initiatives.
And, I think you could see that there were a number of recommendations that were directed towards CDC for their surveillance activities. They're involved in how to improve the systems for delivery of services. And we talked about the broader issues in integrating with chronic disease programs and dealing with upstream environmental social issues. So there is a big agenda for CDC. And although we didn't try to cost out what that would be, that wasn't really in our remit, it's clear that resources are going to be necessary to allow them to fulfill that function at the level that is going to be required. And currently, the program resides within the diabetes program at CDC, and they need to make internal discussions about whether that's the best place or how it gets better integrated with some of the other parts of the organization. We didn't really speak to that. We thought that was a discussion for their internal deliberations.
Hi, I'm Brian Hoffland. I'm president of Research to Prevent Blindness. I wanted to just thank the committee for the work that they've done on this report. My question is, can you describe a little bit, I know that from other IOM, NASEM reports that it's one thing to produce a report, it's another thing to actually have the report make an impact and lead to action. Can you talk a little bit about what are the activities that NASEM is having for this particular report? And then also my question would be, what is it that some of the sponsoring organizations and other organizations could do to help take the report from a document into action?
Well, you're right. It's imperative. If this is a document that you all say thank you very much and sits on a shelf, we will have failed. So as a committee, there are a number of activities. One is to create some materials that some of which you've already seen. There's a brief, there's a set of recommendations, there's the report, there's an intent to create an infographic. And we will be, many of the committee members will be speaking with organizations around the country, some of the organizations that are currently here, and hopefully to many others, to try and motivate, or at least inform groups about what the report says, and encourage the groups to to take action. I think at the end of the day, many of those actions are going to be dependent on the group, because this committee will disband. As a matter of fact, it has disbanded. So that, we hope that others will take up the recommendations, and you will work collaboratively to come up with some common messages and begin to move these agendas forward. As I mentioned in response to Molly's initial question, we will be convening in the spring, and hopefully many of you will participate in that, to actually talk about where we are, what we've learned, what the groups want, and where we go from here. But we're very dependent on all of the important stakeholders to actually help move this forward, and hopefully in a concerted and unified fashion. I know Ed and Ann, do you want to speak to that?
Well, the only thing else is also yesterday we were on Congress doing briefings about the report. So also trying to elevate it in terms of the government being aware of what needs to be done. So.
You know, and Ann mentioned the call to action to as part of her presentation, but that call to action has to extend, I think, to all stakeholders and the public at large, because it is a public health problem, and it can only be solved through a public health initiative. So all stakeholders, all individuals need to be engaged in the process, including those who are recipients of care.
A question from the public specific to myopia. Myopia affects a substantial number of individuals in the U.S. and is a cause of vision impairment. What is being done and what could be done to address myopia in the U.S.?
Well, myopia is a condition, and it is one of the causes for some individuals of uncorrected refractive error. And so there is research currently going on about causes and determinants of myopia at the National Eye Institute and other organizations. So that research is being done. In terms of population health research, it's really the uncorrected refractive error for people that have myopia, that they might not have access to the eyeglasses to help. And also picking up the school children through screenings and then getting them to the appropriate care.
I would add that the committee recognized there were a lot of potential risk factors, such as you know, all the screen time that we spend, that we need to understand better, and how that relates to not just myopia, but other kinds of refractive errors and changes. We struggled because we don't really understand what the interventions need to be to actually begin to think about this more preventively. So we need to do that so that we can have good messages that we can deliver about what works. And then, as Ann was saying, there's an awful lot of uncorrected refractive error out there that needs to be systematically addressed, and many of those vulnerable populations need to be brought into the systems of care to make sure that they get the correction that they need, and then ongoing systems to continue to detect it in a timely fashion, whether it's in kids or adults, and make sure that they get the care they need, which means to break down many of the barriers that the report identifies as limiting access to care, whether it's payment, access, knowledge, and so forth.
Do we have any other questions? Well, thank you all so much for joining us today, and a reminder that the report and related materials are online on our website, nationalacademies.org.